We're now going to start to discuss the second type of drug or broad category of drugs that we use in hypertensive patients or to manage hypertension, and those are the angiotensin converting enzyme inhibitors or ACE inhibitors. This is a large class of medications that has been shown to be very effective in hypertensive patients and is very safe. We use these drugs as what we call a first-line drug for heart failure and also for hypertension. Now, I told you that the first-line diuretic for hypertension was what? Hydrochlorothiazide, a thiazide diuretic. But oftentimes, even though we start someone on a thiazide diuretic, we still need to have them on an ACE inhibitor. So we can combine these drugs to treat hypertension and to treat heart failure, although this lecture is focusing more on hypertension. It's important to note that patients with hypertension take an average of 2 or more drugs to control their blood pressure. And so you'll often find that patients are on many drugs to control their blood pressure. So let's talk about the ACE inhibitors. Before we begin to talk about the ACE inhibitors, I want to go over some pathophysiology with you, or some physiology with you, I should say. And this is going to be important to understand when we talk about any of the angiotensin inhibitor drugs or angiotensin receptor blocker drugs. So pull out this slide. You can look at it while we're talking, of course, but if you have it blown up on a slide, you might want to look at it. And when you're studying, you'll probably want to go back to it frequently so you can really understand how ACE inhibitors and ARBs work. So basically, how the renin-angiotensin aldosterone system works is that the kidneys are our main organ for sensing what's happening with our blood pressure. So if for some reason, for example, a person's dehydrated, they have low volume or low blood volume or low plasma volume, the kidneys will sense that. When they sense low blood pressure, decreasing blood pressure, they release renin. By releasing renin, it makes it available to break apart angiotensinogen to become angiotensin 1. When angiotensin 1 is available, it is broken apart by angiotensin converting enzyme. As angiotensin converting enzyme acts on angiotensin 1, it creates angiotensin 2. Now this is where it gets fun. Angiotensin 2 is a potent vasoconstrictor, and so as it is released or secreted, it causes the blood vessels to constrict or get smaller, right? And so when blood vessels get smaller, blood pressure goes up. If blood vessels get bigger, blood pressure goes down. But in this case, angiotensin 2, because it's a potent vasoconstrictor, blood pressure goes up. The second thing that happens with angiotensin 2 when it's released is that it acts on the brain to cause the release of antidiuretic hormone, or ADH. Antidiuretic hormone causes us to hold on to fluid and also increases our thirst. So let's think about what's going on here. We have blood vessels that are getting smaller or more narrow. We have fluid that's being retained and thirst that's being increased, and therefore our volume may go up, and so our blood pressure is beginning to go up. The third thing that angiotensin 2 does is it stimulates the adrenal cortex, and the adrenal glands sit on top of the kidneys. When they are stimulated, they release aldosterone. As aldosterone is stimulated, it causes the increased reabsorption of sodium, and we all know that where sodium goes, water goes, and so then as we reabsorb sodium, we reabsorb more water, and more water in our tank or our blood vessels causes blood pressure to go up. So while the kidneys originally sensed that there was low blood pressure, this chain of activities occurred, and by that occurring, we get blood pressure to actually go up. Once blood pressure goes up, these activities slow down or shut down. And so it's a feedback loop, essentially. So it's important for you to understand this in order for us to talk about what these drugs do. So when we give someone an angiotensin converting enzyme inhibitor, if the person has high blood pressure, let's say the person has hypertension, has hypertension. I'm going to abbreviate that here. If the person has high blood pressure, we want to see what we can do in this system to trick the system to stop making angiotensin II. And the way that we do that is to block angiotensin converting enzyme. If angiotensin converting enzyme cannot break apart angiotensin I to create angiotensin II, then you're not going to get vasoconstriction that increases blood pressure. You're not going to get increased thirst or release of antidiuretic hormone. You're not going to get the release of aldosterone that causes sodium reabsorption and fluid retention. And so in that way, we can bring down blood pressure. And that's how ACE inhibitors work. So it'll be very important to know that. And this is just a review of how that works. Angiotensin II is blocked, aldosterone is blocked, and decreased sodium reabsorption. So this is just a slide that summarizes exactly what I just said about preventing the sodium reabsorption, decreasing preload, which decreases blood pressure, and causing vasodilation, which also causes a decrease in systemic vascular resistance. And remember, that's just a fancy way of saying decreased afterload or decreased blood pressure. So this is the take-home message right here. So ACE inhibitors, why do we use them? We use them for high blood pressure. That's why we're doing this lecture. We use them in hypertension to break the cycle of the renin-angiotensin-aldosterone system so we can decrease blood pressure. We also use them in heart failure, and I'll talk about this a little bit more when we do our heart failure lecture. We also use them after a myocardial infarction. Remember, I talked about how some drugs are used that are considered to be protective, and this is one of them. ACE inhibitors can protect the myocardium after myocardial infarction, and that's why we use it. And these drugs are also have renal protection, especially in patients who are diabetic, and that would be important to know as well. Our exemplar drugs are lisinopril. Lisinopril, brand name Prenavil or Zestril. These are newer drugs. They're longer lasting. Usually you take them once a day. The older drugs like captopril and enalapril have a shorter half-life and sometimes only available in certain forms. There's a very long list of ACE inhibitors that are available. You can see table 22.2 in your textbook. This really is our exemplar drug. And you'll notice too with the ACE inhibitors that they all have this suffix of pril for the most part. So that can tip you off to know that that is in fact an ACE inhibitor. The adverse of ACE inhibitors, well, let's think about this. If our goal is to bring the blood pressure down, but for some reason the blood pressure goes down too far, you're going to have hypotension as an unwanted side effect or an adverse effect. Things that are associated with hypotension are fatigue, dizziness, headache, sometimes mood changes. So these can be bothersome, and this is why the nurse has to watch the blood pressure or monitor the blood pressure of a patient that's been started on an ACE inhibitor. Things that can be a little bit, one of the adverse effects that can be a bit annoying but is rarely dangerous is the dry, non-productive cough. This isn't like a cough you get with allergies. It's not like a cough from a cold. It's a cough that is has to do with the way that the angiotensin converting enzyme inhibitor itself breaks down bradykinin, and when it does that, it triggers the cough reflex. For some people, they don't have this at all. Some people, it's horrible and annoying, and they just absolutely cannot tolerate being on an ACE inhibitor. For some people, it barely bothers them at all. So it's important to ask the patient if they have that or how much it bothers them. If it's really bothersome to them, then we have to stop it and start another medication. There's two other side effects that are pretty serious that we have to watch carefully for with ACE inhibitors, and it's very important that you know these. One is possible hyperkalemia. Patients that take ACE inhibitors should have a potassium level drawn every once in a while to make sure that the potassium is not getting too high. So hyperkalemia can be an adverse effect of an ACE inhibitor. Another one is angioedema that we're going to talk about in just a minute here. This is a rare thing that you'll see, but every once in a while you do, and it can be life-threatening. The other thing that, as far as adverse effects that we just talked about with hypotension, is that this hypotension can occur even on the first dose. So usually when we give the dose in the office or we give the first dose in the hospital, we're carefully monitoring the person's blood pressure before we let them be discharged or leave the office to make sure that they're not going to be hypotensive. So think about this when we're talking about ACE inhibitors, about what's our nursing assessment for these folks. Definitely a blood pressure, at least before they leave your area of observation. So I mentioned angioedema. This is just gives you a picture of it. It looks a little bit like an anaphylactic reaction, but the mechanism of how it occurs is completely different. But the person will get swollen mouth, swollen tongue, and swollen face. And this, as you can see, can become severe enough that it can block a person's airway, which makes it a life-threatening emergency. The person should go to the emergency room, or maybe they'll hopefully be in a place where they can get that emergent care anyway. All right, so that's ACE inhibitors. Now, sometimes people don't tolerate ACE inhibitors. Think about the reasons why. They could have angioedema, they could have hyperkalemia, they could have an ACE cough. So we're thinking about, well, what's another way that we can disrupt that renin-angiotensin aldosterone mechanism? And to use angiotensin II receptor blockers is another way to do that. So these medications are newer, they're well tolerated, and we know that they don't cause that ACE cough usually, but they act very similarly to an ACE inhibitor. So how do they work? There's the renin-angiotensin aldosterone system, and they block the receptors for angiotensin II. So all the receptors that would be in the blood vessels or the brain or the adrenal cortex are blocked so that they cannot perceive what's going on with the angiotensin II. So you don't give vasoconstriction, secretion of ADH, and stimulation of the adrenal cortex, which increases aldosterone secretion. So that's wonderful, and when that happens, that can bring blood pressure down. One thing I do want to mention about ACE inhibitors and aldosterone receptor blockers is that nothing's 100%. So even if we block ACE inhibitor, angiotensin converting enzyme with an ACE inhibitor, you're still going to have some angiotensin converting enzyme that's secreted and some change from angiotensin 1 to angiotensin 2. If we give an ARB, you're still going to have some angiotensin 2 that's secreted. So that's why sometimes we have to actually give both of these medications. Or you'd ask, why wouldn't you just use an ACE inhibitor if it's working? Well, it's because we get a little bit of bleed through is what we call it. Not anything you really have to worry about, but just to answer the question of why would you have to do that. So this is just another slide that talks about the angiotensin formation, angiotensin 2 formation, and what it does, just to give you another graphic of how it works. And this is exactly what I mentioned before of how it works. It blocks vasoconstriction and the release of aldosterone, and thereby causing vasodilation and decreased sodium reabsorption, which causes blood pressure to go down. The exemplar drug is losartan, so you can see that that losartan has the suffix of artan or tan, so losartan, valsartan, irbesartan, eprosartan, and there's many others as well. Cozar Hyzar is the brand name of losartan. Many are generic, and they vary in the same way ACE inhibitors do with their half-life and efficacy. So why do we use them? For hypertension. We use them also with ACE inhibitors and other drugs for heart failure, and we'll talk more about that. And we really like to use them in hypertension for those folks that can't tolerate an ACE inhibitor. So when you're studying this, think about why someone may not be on an ACE inhibitor, and then know that they may be on an ARB. What are the adverse effects? The main ones you're going to be tuned into are those that are the side effects of hypotension, which would be occasional dizziness, fatigue, that type of thing. We see much less hyperkalemia than we do with the ACE inhibitors, so that's why we also like ARBs a lot of the time too. And so now I'm going to pause here. Our next slide set is going to be on calcium channel blockers and adrenergic drugs. And if you'll study ACE inhibitors and ARBs, I think you'll do great. Thanks.